New Dyson Airwrap Co-Under 2X Multi-Styler, supercharged to deliver 2 times the air pressure for even more power. A straighter finish, better wrapping, faster drying. One machine, multiple expressions of you. From Dyson.
Good morning. That's a very good morning. Good morning. Oh, y'all can do a little bit better than that. Good morning. We just want to go ahead and get started this morning. Welcome again to our lung cancer seminar this morning. We'd like to thank you again for coming out early in the morning. If you were here yesterday, clap your hands. If you were here yesterday, clap your hands. Well, thank you so much for being here again. I'm Stan Wanster, National Director for Policy and Faith-Based Initiative with HEAL of Collaborative. Along with our sponsor, Amgen, we welcome you again for our Saturday edition of our lung cancer seminar here with the Sheffield Bridge Center. We also have St. Patrick with us this morning, and we wanted to give them a hand because they're watching live and understand that they have a full house. So let them know that we're watching them as well. Justin, Reagan, and Yolanda. Y'all got to clap your hands for them. They're looking at us live. All right, they are watching us live over there at St. Patrick, so we appreciate them as well. Well, let's get started. I'm going to ask Minister Cynthia Lamb to come up and grace us with the invocation. She'll be followed by Ms. Stephanie Price, who will bring welcome on behalf of Pastor Sheffield with the organization, the New Destiny Fellowship Church, and also the Detroit Association of Black Organizations.
Good morning. Praise the Lord. My name is Minister Valerie Lamb, and I am Associate Minister at New Destiny under the guidance of Bishop Horace Sheffield. I also sit on the board of Dabo, and I'm also his assistant. But most importantly, I am a Christian, loving God. And I ask at this time that we do what the only thing that I know to do to open up a program as important as this is that we bow our heads in prayer. Our Father, we come to you on this day saying thank you. Thank you for your grace. Thank you for your mercy. Thank you for allowing each and every one of us to get up and make it here today. We ask that this time that you open our minds, our heart, our ears, so that we may learn and we may return and retain this valuable information that will be put before us. Lord, we choose not to be gatekeepers and sit here and just absorb this, but we ask that you do more than tenfold and you allow us to take this knowledge into our community, Lord. Let us touch those in our home with the knowledge. Let us touch our children, our grandchildren, our neighbors, each and every person. Let us spread this word so that we can help our community because, Lord, in these times, we know that we have to help ourselves through your strength and only your strength. Lord, I say to you now, Lord, let us be a beacon of light, a beacon of light. Let us become more knowledgeable about the health industry. Let us keep the vapes away from our children, the cigars and the whatever they roll the marijuana in, 41, whatever that may be. Let all of that just cancel, 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 and remove it at this time. And I say this in the name of the Father, the Son, and the Holy Spirit. Amen.
Right. Thank you, Ms. Lamb. Stephanie, here you go.
Good morning, everyone. I'm so thrilled to bring this welcome to you all this morning. Of course, I hate to disappoint you because I'm not Reverend Horace Sheffield. I hate to disappoint you, but I'm Stephanie Pride, and I am the proud chief of staff at Dabo. And when I say having you here today and yesterday and on this campus, it means so much to us. This building was was dilapidated. They left this building to go. It was forgotten. It was a library, thriving library in the city of Detroit. And we together, Reverend Horace Sheffield was able to garner the financial support to bring this library back to life and bring and open it to this community so that we can have community forums like this. We have community forums like this. We have entertainment series like this. This right here is a resource center, and we could not be more proud than to offer events like this. Advocacy is huge for Dabo. People often ask me and say, Dabo, what in the world is Dabo? You know, Detroit Association for Black Organizations is what we used to go by, but it actually turned into an advocacy. Where down the street is our other Sheffield Center, where you see some of our people who are trickling in. How many of y'all are at the community breakfast? There's a couple of us that was already at the community breakfast. Every Saturday morning, we have a radio show, community breakfast, down the street where we host more than 100 people. Free breakfast every Saturday. Then just think, you can come down here and get a free cancer screening. Screenings are so important, and I would even throw myself in there without taking too much time. But last year, I was diagnosed with stage 4 breast cancer metastasis. And I know some of y'all faces like, oh my God, but I give all glory to God because I'm still alive and I'm still here. But the tragedy to my story is that I went so long without any symptoms, without anything, not knowing that I had cancer in my body. I had no symptoms. And then one day I became symptomatic, just very tired. My arm was hurting. And I went to the doctor, I went to the ER, and then they said, you have stage 4. Can you imagine? Like living your life. I was on my way to Africa doing a missions trip, and I had 45 delegates waiting on me over there, and we were meeting to go to Kenya. We was going to Kenya this time. And I had to call them and tell them I couldn't go because I'm laying up in ER with them trying to explain how in the world did I get stage 4 that fast, right? And so advocacy, early detection is critical because literally I'm fighting for my life. Literally, I'm doing everything I can to live, and I thank God for His goodness and His grace that I'm here. But I've come to know in this cancer journey that each cancer is different. So that's again why we're so proud to be sponsoring today, talking about lung cancer, because lung cancer is huge and it affects our communities in more ways than one. And once we realize that we are so intertwined and so connected, you know, just look around your table. We are so connected in so many ways, and it is our responsibility to be our brother's keepers. You know, at Dabo, we are very tight-knit family, and we hope to share some of that love and that respect today while you are here in our premises. And we hope to learn so much more, and hopefully we can equip you with some tools that when you leave here, that you can, you know, spread the word that early detection and getting checked out is so critical to saving lives, because we need you to survive. And if I was Horace Sheffield, he would end with this saying, death can wait. Thank you.
All right. Thank you so very much. All right. Vanita Kapoor, stand up with Amgen. Y'all give her a hand as our sponsor this morning. Thank you for being here again this morning with us. I appreciate you so much. Speaking of screenings, guess what? We're going to be doing lung cancer screening this morning. We have a person from the Henry Ford Hospital. Cindy, you want to come up and tell them a little bit about that? Come quickly and just do that for me. That's okay. We got to go on camera. Yeah.
Well, welcome back to those who were here yesterday. And for those who are new, welcome. I'm Cindy Lambden. I'm the nurse manager for Henry Ford's Lung Cancer Screening Program. And I have with me today 2 of my team, Sherry and Rachel. We're here to assist you with signing up for lung cancer screening. Our intent is today is to go over the eligibility forms. There are hard copy papers that are I believe, being put out now for anybody who would like to have their eligibility checked for lung cancer screening. And then our intent is to actually get you scheduled. so that you can actually just come on in and get that lung cancer screening done. Now, one of the things we want to make sure to go over is what are the eligibility criteria? Remember that we said yesterday, Henry Ford follows the Centers for Medicare and Medicaid eligibility. And that's because the majority of health insurances actually follow that rule instead of the preventative task force up to 80. But so right now, if you're between the ages of 50 and 77, if you are a current or former smoker, if you have at least a minimum of a 20-pack-year smoking history, you meet the eligibility criteria initially. And then we're going to dig a little deeper. We're going to be asking questions about symptoms that we recognize could be indicators that you may have something going on. And those indicators are actually on that form that you're going to be looking at this morning, okay? So we want to see if you're asymptomatic. And if you don't have any symptoms, then that kind of really opens up the way for you to have your lung cancer screening done. And right now, we have a fair amount of room on our schedules to actually get you in, even within the next 2 weeks, so that there's no delay at all in getting you in. And I just want to make sure that, if you are over the age of 77, don't fear. We have ways to work it. Never say never, because I will find a way to help you get through a process. And that's the whole point of lung screening. It's really about early identification, early treatment, because when we identify our cancers early, then we actually can treat and cure them. And that's the whole goal of today. Okay? So we look forward to seeing you. And Sherry and Rachel and I will be taking care of you a little bit later on this morning. Thank you.
All right. All right, we're going to do the audience polling questions again. Let's try it again. We did it yesterday. We did it online. All right. If you have your telephone, we did pretty good yesterday now. Come on. It was the first time. This is the second time now. Okay, we did pretty good yesterday. So if you're online and you have your phone, you go to menti.com and then you can join on this code 89223717. Now, if my daughter was here, I would tell you to capture the QR code, because she does all this for me. Capture the QR code, and that way we can make sure that we can get these questions answered as well. What do you think, Shayla? You think we can try it again? All right, let's try it and see what comes. Are you guys ready? St. Patrick, are you ready? Okay, they said yes from across the street. Okay. Before today, how familiar are you with 340B drug pricing program? Okay, at least until our first topic, so that's pretty good. Okay. All right. Second question, how would you describe your current mental wellness? This is before Ashley comes up, so make sure you answer this question correctly because she might have something to say about this. How would you describe your current mental wellness? Okay. All right, St. Patrick. All right, Sheffield Bridge Center. Okay. Do you currently smoke or use tobacco products? All right, Dr. Flano, well, let's see what we're going to do here. Do you currently smoke or use tobacco products? Not how much you smoke, but what are you smoking? Okay. Do you currently smoke or use tobacco products? Okay. Okay. All right. How confident are you in your knowledge about healthy nutrition for cancer prevention and treatment? How confident are you in knowledge about healthy nutrition for cancer prevention and treatment? This helps Anthony out a little bit before he does the presentation, okay? All right. And have you ever had lung cancer screening or been told you might qualify for one? Like Cindy just told about screening that we're going to be doing today. So have you ever had a lung cancer screening If you get screened today, you can answer yes to that question. How about that? Okay. What do you most hope to learn or take away from today's program? What do you most hope to learn or take away from today's program? Okay. Got certain titles coming up. Okay. Education, how to get a screen, what to do, symptoms of colon, get a lung cancer screen, knowledge, 80 steps to prevent cancer. What do you most hope to learn and take away from today's program? Okay. Is that it? Oh, give yourself another hand. We just did AI information again. Boy, y'all, this wasn't even Georgia Tech, Howard. This was very good. Thank you so very much. That was good. All right. Okay, let's move into our first session. It should be quite informative because we answered some of the questions. I'm going to ask that our panel members come up first before we introduce the moderator. Jerry King is president of A. Philip Randolph Institute, the Michigan chapter. We asked Mr. King if he would come forward and join us on the dais here. Howard Mosby, my boss and co-founder and board member of Hill Collaborative. Come on up. Josh Spagnola, director of regulatory strategy and corporate and state government affairs with AstraZeneca. And Representative Billy Mitchell from somewhere called Georgia. All right, you guys will come on up. And I think you got mics there, and I'm going to give my mic up in just a second. All right, they're going to be discussing 340B, and I'm going to have the gentleman's going to moderate and give us a overview of it before we get started. That's going to be Mr. Thomas Johnson. He's the executive director of ASAP 340B, a national organization with he has 30 years of professional experience in the healthcare industry. He's served 9 years as president and CEO of Medicaid Healthcare Plans, trade association representing healthcare plans in the business. He's also led advocacy efforts in involving the Affordable Care Act. He was also president and CEO of the DC Hospital Association. Mr. Johnson also served as vice president of compliance and external affairs with the DC Chartered Gorman Health Group, a consulting firm focused on assisting government-sponsored Board of Trade and legislative director with the Medicaid Society of the District of Columbia. Mr. Johnson also served on a number of boards and commissions. He's currently the chair of the board of the Sickle Cell Disease Association of America, other humanity councils of Montgomery County, and the DC Association of Health Maintenance Organizations. And he's going to serve as our moderator if we go through 340B, which has been prevalent in our community today as we look at the prices of drugs and benefit managers across America. Will you give our moderator, Mr. Johnson, a hand as he comes this morning?
Good morning, everyone. I'm happy that I've been able to join you from Washington, D.C. This is my first time in Detroit in about 30 years. I had a aunt that used to live here, and the city has changed quite a bit since the last time I've been here. I had a chance to go by Ford Field and Comerica Park and see all the development over there. So it's really a pleasure for me to join you in the city and join you this morning. I'm going to talk about the 340B program. I think when I talk to audiences like this, some of them are aware of the program and what it does. Some aren't. I think increasingly more and more people have learned about the program, but I'm just going to give you just kind of a basic overview of it and what it does, and then talk about some of the things that we've been concerned about as a coalition. And I'm happy to say that both the HEAL Collaborative and Choose Healthy Life are members of our 36-member coalition that are seeking needed reforms in this program. So essentially, the 340B program is this. It's a program that was created so that covered entities that serve the underserved population, like hospitals, like community health centers, like Ryan White aid clinics, they are able to acquire drugs at a discount and then provide them to the people that they serve. The discount is currently averaging around 59%. They are also able to keep that 41% that they would have been charged otherwise. So they're able to keep that. And so that helps those entities out financially. So when that program was created over 30 years ago, that worked for those covered entities, that worked for the patients that they serve, that even worked for the manufacturers. But there are things that have happened over the last few years that I want to open up and address, and then have our panelists speak to some of the issues that they deal with and that they see with regards to the 340B program. So you'll see in the first slide, recently, studies show that this program, which really was created again to serve the underserved through those covered entities, it's starting to not work as intended. The program has expanded significantly. So right now, the purchase amount of those drugs that are purchased under this program is $66.3 billion. The actual price of those drugs are $126 billion. The number of covered entities have grown, but what we've also seen is that there are groups like PBMs that are starting to become part of this program. And they are now involved in the pricing of the drugs in the program. So what's happened now is that instead of certain covered entities, again, getting that 59% discount and keeping that 41% discount, what they are now doing is they are charging Medicare, Medicaid, and commercial insurance as much as 500 to 1,000% and keeping those dollars. Hospitals keep 87% of that 66.3 billion, and they're the largest beneficiary of the program. There are few transparency and accountability measures. There are none required by the 340B statute. So we have seen stories of hospitals spending money on things like capital improvement projects. That's not related to healthcare. We've seen stories about hospitals buying a Super Bowl ad that ran for $8 million in New York. We've seen studies of a university in Florida that spent their money on the salary of their football coach. This isn't reinvesting money in healthcare. So entities can use the savings for pretty much whatever they want. Hospital consolidation. 340B benefits are flowing away from low-income communities. There are stories of hospital systems that are building what's called child sites outside of these underserved areas. They are eliminating some of their programs in underserved areas, and they are extending this 340B discounted price to those affluent areas, which is not what was intended under the program. You can see by the charts, 87% of the purchases in this program are made by hospitals, and you can see the growth over a period of years. Last year, the growth of the program was around 23%. And if those numbers keep up, this will be the largest prescription drug discount program in the country. Next slide. 340B hospitals are providing less charity care. Research shows that these hospitals, on average, devote a lower percentage of their operating expenses to charity care than other types of hospitals. Now, understand, these 340B hospitals, in most cases, have tax advantages that for-profit hospitals do not have. So they're paying 2.15% on average. Nonprofits are paying 2.3% on average, and for-profit hospitals are paying over 3%, close to 4% on average. Next slide. We're starting to see some work done with regards to specific diseases in 340B. For the purpose of today, there's work been done by a number of organizations, not only involved with our coalition, but also with the American Cancer Society. And they show that even though 340B hospitals buy drugs at steeply discounted prices, many cancer patients find themselves paying more. 340B hospitals use higher cost cancer drugs, netting larger profit margins. Revenue earned by those hospitals for cancer therapies was over 10 times that at non-340B hospitals. So when Senator Cassidy from Louisiana makes a statement about what's happening with the 340B hospitals system, he's saying now this is part of an earnings call. And what's not being talked about is that what this is doing for the underserved. In Michigan, 340B hospitals spend 20% less revenue on charity care than hospitals as a whole, and are marking up drug prices by 800% on what they pay manufacturers. Again, this is starting to become a profit center for these 340B type hospitals. Patients are also often struck with the bill. And one example, a patient was billed $22,700 for a drug that cost the hospital $2,700. So again, what's happening is because the statute is silent, hospitals have very smart people that work for them. They look at the law and they see what they can and can't do, and they are applying these practices accordingly. Next slide. So again, we'll talk about Michigan. Michigan's 340B hospitals, as we stated, spend 20% less revenue on charity care than hospitals as a whole. Studies show Michigan hospitals are marking up drugs by 800% of what they should pay manufacturers. Michigan hospitals have an 0.75 charity care rate, far below the national average of 2.28. And the University of Michigan hospitals and health centers have a total operating expense of $4.3 billion and only a 0.63 charity care rate. Something to think about. Next slide. So we're going to get started with this background that you just heard and start to hear from some of our panelists and what they think about this program and how they think things can be reformed. So I'm going to start with Jerry King. Jerry's with the A. Philip Randolph Institute, the Michigan chapter. And so from a union perspective, how does the misuse of unchecked expansion of this program affect the overall cost of healthcare for workers? And related to that, what will be the impact of the bill that's moving currently through the state legislature?
Okay, so the first question was what's the impact on working families,
Mhm.
basically?
Mhm.
All right, so the impact of the profits from the companies taking these profits and utilizing them for themselves instead of making them affordable for our community, marginalized people, it impacts us because a lot of us can't get the medicines we need. We wind up getting denied. Matter of fact, I'm a UAW international servicing rep, and I suffer with diabetes, right? And one of the things that really helped me get it was out of control. I was at 500 when I found out I was a diabetic, right? And I stayed high often for a long time. So I have one of the best insurance policies in the nation, right? So when I had broken my foot and I needed to get in 3 places and I needed to have surgery, I couldn't have surgery because my sugar was out of control. My numbers were too high. So I went and got a specialist, which my insurance was able to provide me, and they put me on a plan. One of them was the instrument that checks your blood sugar and sends it electronically to my phone. It tracks it. It makes it easy for me to be able to look at my numbers real time, look at my averages and things of that nature. And that helped me drop my sugar and get it under control. And now, currently, today, I can't get that because of the costs associated with it, right? And this isn't a pharmaceutical, but it's just one thing of of tools and things that are prescribed to us where the prices are astronomically high, and corporations are taking this money that could be utilized and funneled into our communities to make sure that we can get the medications that we need so that we can take care of ourselves and keep our issues in control with affordable medication. So it hurts our communities. It hurts our members across the nation. And for those who don't even have collective bargaining, we know they're left out of the table. They don't have the same resources we have to help deal with co-pays and to deal with being able to get affordable medicine. So the current legislation that is going through, and actually we got involved with this back in December during the lame duck session. Our national president, Cleola Brown, APRI, she called us and said, hey, this is dear to my heart. I need you guys to work on this. So she got teams across the nation of APR chapters to get involved locally. And so I'm the state president and the Detroit president of Metro Detroit. One of the first things we did was actually put together a letter and identifying with talking points that we got from our partners on how much this costs us, how much money is being siphoned off by the corporations. And so the current legislation that they're moving, we were able to get amendments to put in transparency and accountability measures. All right, because at the end of the day, this bill 340, the initial parent piece of legislation, was put in place to make things affordable for us, but it's not happening. It's going to the CEOs. It's going to stop buybacks. It's going to many other things that have nothing to do with who it was written for. So we were able to put enough energy behind where it did not get out of the lame duck. All right, that's when they were trying to pass it. They moved it on, they changed the name and tried to move it in the Senate. So we sent another letter to the House, to their committee at the Senate level to try to slow this down and tell them that your version of the bill still is not addressing transparency and accountability. And so we really believe that with the way this bill is moving now, it's going to open the door for further abuse, and we're not going to be able to put the genie back in the bottle. And so it's very important that we get involved, that we come to meetings like this and learn how these things are impacting. Learn and watch where the money goes. If you watch the money, you see where it goes, you understand we're not benefiting from it, and it was written on our behalf.
Thank you. Appreciate that. Representative Mitchell, why don't we follow up with you? I understand the legislature considered a bill this year that included potentially harmful provisions, but it did not pass. What's your assessment with regards to what might happen in the next session?
Testing. Good. Good to be with you. First of all, it's so good to be with you. I'm so glad that the Hill Collaborative has put this brain trust together. I myself have learned so much in the last day or so. And we're very fortunate to have companies like Amgen who can really support these type of efforts for us to get the information. You ministers out there know, our folk, we suffer mostly because of a lack of information, and to be able to get this is just wonderful. I think I ought to say that I am pro-business. I am a pro-business type of legislator. I understand that it's important to have companies make as much money as they ethically can, so that we can have jobs and pay taxes and the like. So don't jump on me because what I'm going to say next. I'm a fan of companies. However, the 340B program, it had a very noble purpose when it started. Being from Atlanta, I think I can quote Dr. King. He says, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. You know, the rich, they're not, you know, what the rapper said, they're not like us. They really aren't. They get a different kind of healthcare delivery. They get a different kind of legal delivery. I mean, they're just not like us. The 340B program was put into place to provide equality. And when I talk about equality, I'm not talking about treating everyone equal. I'm talking about giving everyone an equal opportunity. You know, I can get, Gabriel, are you the one that gives the sign when I talk too long? I can go on it because I'm really passionate about this. But the reality is, in Georgia and Michigan, I looked, you need a heart transplant. If you are too poor, you can't even get on the list. Only rich folk who can afford it can get that, unless you got some altruistic organization that's willing to donate to you. The rich, they're just not like us. And that's why the 340B program was put into place, to provide equality. Now, what has happened now, and for a variety of reasons, our healthcare delivery has gotten so expensive, and that the hospitals, maybe I should say, those certain entities have want to meet their profit margins, and they found a way to do that through the 340B program. And one of the ways we've got to deal with that, we had legislation. Georgia's one of those states, if you bring enough business to the state, they'll literally give you their checkbook. Georgia's one of those places, it's one great place to do business, but we've got to hold them accountable so that they can provide the equality that we need. And that's what's going on. I'm so glad that legislation did not pass, but based on the political climate that we have in Washington, I'm afraid to say that some of us in this room are not valued. Our health is really not valued. Based on the political consequences of certain folks who think more conservatively than I do about helping the indigent. Based on those kinds of issues, we've got some dilemmas that we're going to have to face. But fortunately, we have advocates, and every single one of you in this room is an advocate. Whether you vote or not, if by you not voting, you're really an advocate, because you're demonstrating to them that this is an issue that's not important to you. But if you get out there and be an advocate, the statistics will say even, about 60% of you only vote regularly. Now, because you look, all you folk in this room look smarter, we're at the Danville Center here, maybe it's 70%. But the reality is, we can advocate for a better change, for better transparency, for better measurement for these issues, so that we can get true equality in this program. I see you getting nervous over there, Gabrielle.
Howard, from your experience in working with underserved communities and seeing 340B implemented firsthand in a hospital system, has the 340B program benefited low-income patients?
So again, like Representative Mitchell, I first of all, I want to thank you all for being here. Great question. 340B did have its origin is absolutely beneficial to the community. There are hospitals out here that are really knocking it out of the park. The fact that Henry Ford is in here providing lung cancer screenings, so that's how 340B dollars are used in this space to be able to help communities be able to bridge these gaps. And so it's great to have a hospital that's using dollars to help support the community. Nobody in here was charged a fee to come in here. Nobody's gonna be charged a fee for lunch. Nobody's gonna be charged a fee to get these screenings. And that's how these dollars are supposed to be used. But then there are organizations out here that are actually taking those dollars, as you pointed out, that they are buying things that are not healthcare delivery related, which these dollars are designed for. The other thing is that these dollars, none of these dollars are government dollars. They all come off the bottom line of pharmaceutical companies. So when you look at that $66 billion number, it's not any government money coming out of a taxpayer's pocket. It's coming right off the bottom line of an organization. These organizations are asking for, can we at least know from a reconciliation standpoint how these dollars are being used? And the pushback has been, we should be able to use the money the way that we feel that we need to be able to use it. So that's not a good answer for neither one of us. When people ask us questions about how we use our money in this organization, Hill Collaborative, how do you guys spend your money? I could say, what did God tell Moses? You look at my hind parts. That won't fly long. So it's best that there's some level of transparency in there. So there are a number of hospitals. There's some in West Virginia that are doing it well. There's some, around the nation. But really, as consumers of healthcare, you should be more interested in trying to figure out, am I a 340B patient? You're a 340B hospital. How are you using your money? Those three questions are extremely simple for you to ask your healthcare provider whenever they're telling you, we're not going to pay for your outpatient.
Josh, from a manufacturer standpoint, what are your key concerns about the way the program is currently being implemented?
Thank you, Thomas. And I appreciate HEAL and the work that they do, because this is a very complex topic between drug manufacturers, hospitals, the pharmaceutical middlemen, PBMs, and we get stuck in that conversation. We forget at the end of the day who the program is supposed to benefit, and it's people in the community. It's a safety net program, and so I really appreciate the fact that HEAL brings this conversation into the community, because that's where it really belongs. From a manufacturer perspective, I agree with what Thomas was saying, in that when this program was created, we fully supported the intent of the program to be a safety net program, to help hospitals carry care programs, provide indigent care in areas of need. We've seen a tremendous growth in the program, as Thomas mentioned, and one way that we've seen it is through something called contract pharmacies, and that's really the vehicle for how these drugs have gotten outside of the areas that they are intended to be served in, and have started serving more affluent communities and started giving resources to build towers used for operational expenses. So in 2020, a lot of drug manufacturers said, if you're a hospital, you can only use your in-house pharmacy. If you don't have an in-house pharmacy, you can use one contract pharmacy. That caused a lot of concern within the hospital industry, and that's what's led to a lot of this conversation in the state, saying we should be able to use as many contract pharmacies as we want. In 2020, when we did that, the spend in the program was $38 billion. As you've seen, it's gone up to $66 billion. So that's after our restrictions were put in place, the program has more than doubled. So to answer your question, we want to check the program. We have some responsibility to make sure that dollars are being spent appropriately, that they're not being used for non-340B patients. And one way we did that was to limit the use of these extra pharmacies outside of the main hospital. The program still doubled. So I think understanding where the dollars go in states, how many dollars come in, how they're being used, because like Howard said, there are a lot of programs in hospitals that really do provide mobile screenings like this, unique programs to serve on and underinsured people. That's the way it should be. But we should get some line of sight into what the dollars are being used for appropriately, and what we would say are probably beyond the scope of what was designed for. There's some other unintended consequences with unfettered growth in the 340B program around Medicaid, increased premiums for small businesses. And if we have time, we can dive into that too. But the larger the program grows, the less it serves the purpose it was meant to, and the more it drives up costs in other areas like Medicaid and small businesses, which are so important in all communities.
Howard, why don't you follow up with that? If the policy changes aren't implemented to realign the program with its original mission, what would be the consequences for the communities and the patients that are there?
Yeah, so great question. understand that this is a federal program. So 340B was part of the 1992 Public Service Act that was issued out of Congress in 1992. In 1992, I was about 3 years old. Just so you know. And that shouldn't be funny. Okay, anyway. But what's happening is states are starting to, like Michigan and like Georgia, have introduced legislation to try to manage the 340B program one way or another, either allowing for covered entities to charge whatever they want to or clamping down. The problem is, sir, that you need a federal solution. Because if you put in 50 different solutions, all bad players are going to do is start shopping where they actually buy their drugs. And so what we need from a national standpoint is for either Congress or HRSA, the health. What's HRSA? I'm sorry. It's the federal government. HRSA is actually the entity from the federal government that manages this. They actually could bring in more auditors to audit the program, and they can also put in rules around 340B that could actually govern this more, instead of having each state, these legislatures bringing in bills that are making this law uneven across the country.
Health Research and Services Administration.
There you go. Health Research and Services Administration. I don't want to sound like I was stupid.
Gary, let me come back to you. Maybe I can ask you about the current environment regarding healthcare costs for employees, and talk about what you're seeing. Are you seeing cases where workers have to make difficult choices about care or coverage? When these costs are going up, how does that affect their ability to provide and receive competitive wages and benefits? Can you talk about that?
Well, I'll definitely state that there's a lot of diversity and healthcare provisions based on collective bargaining, right? I come from the big three, where we don't pay a dime for healthcare. All right, I've never paid a dime for healthcare. Now I'm an international rep and I have a different program, which is still very good. But the big three is out of UAW is 140,000 members out of 370. All right, 377,000 members. And for those industries that don't create the type of wealth that we do, don't receive the type of wages we do, it's a struggle for them. It's a struggle at the bargaining table, because healthcare, even at our level, is a constant fight. It's something that they put on the table that it costs them to the persons we're bargaining with. It's a cost for them, and it's been a legacy cost as well. Our retirees were offered a Viva Trust to shed the legacy costs of taking care of healthcare benefits for them in their retirement. All right, and that has lowered the quality of life for those members. All right, and some of those members have to make decisions on paying the bill or getting the medicine they need. So it's definitely a struggle. It's part of the discussions in every round of bargaining and at every level. And I'm just talking about the UAW, right? Let's talk about those that don't have collective bargaining, but have employers that are willing to provide health care. All right. But without, and the pharmaceutical costs and those things associated has to be part of that discussion, right? And so if these companies are taking these profits and enriching themselves, making it into the CEO's compensation, buying and growing their business outside of the scope of helping the people with that money, then we need to make sure we put some transparency clauses and accountability language at, as he said, at a national level, so that the playing field can be the same across the board and make our bargaining power, where we have bargaining, even more solidified. Like we say, we like to pattern bargaining. If you put that and get that in order, it makes the things a lot better for working class people across the nation when we get an established level across the board all over the nation.
Representative Mitchell, if the goal is to ensure the program truly benefits underserved patients? What types of reforms or safeguards do you think make the most sense for the people in the state of Georgia?
Okay, first thing we do, we take all these folks and others and we sign them up with AFL-CIO, get that 100% healthcare coverage. That's powerful. Do you need an assistant? Could you help a brother out? I can tell you that is, as many of you, if not all of you know, that certainly is not the norm. I have some of the best health care in Georgia as I'm on the state's plan. And I tell you, it gets ridiculous and more ridiculous each year. It starts to cover less and less each year. Um, but to specifically answer your question, if done right, um, it, this should not be a profit center for the providers. If its intent is to make sure that we take care of the indigent, those who can't afford it, it should not be where they list this as a profit center. As a matter of fact, I remember the days um, when entities would try to outdo each other in providing care to the indigent, and they would brag about all the things that they're doing to uplift the community and the like. And now, and I must say that the economic climate that we're in, we have some folk who don't believe that certain communities need to have the kind of health care that this was first put together for. And so it's a different kind of thinking now. But nonetheless, those kinds of issues, hospitals who receive these funds, they should be tracked, they should be measured, they should be accounted for to ensure that they're reinvested. This should be such a transparent process that any one of us should be able to go to their website to see exactly where these funds are going and what they're doing. And until we can do that, I think we're going to have those problems. I don't know why we have some entities, and I'm sure no entities in this room, fight being so transparent about these funds. I don't know why we have that. I talk to legislators from other countries, and I always try to talk to them to see how they grapple, how they deal with the issues that we deal with. And I was talking to a friend of mine who's a legislator in Canada, and their healthcare delivery, the cost for their healthcare is so much less than ours, so much less. They don't have these issues where the very wealthy get one standard of health care and the very poor get another standard. And this is one of the things that the 340B program was created to alleviate, and we must find a way to make it so public and transparent that those who don't abide by its original intent will be shamed into doing so.
Josh, we just went through a period in Congress where this big, beautiful bill, or whatever you want to call it, was adopted, and it made cuts in Medicaid that were historic in nature. I have talked about the fact that since this has happened, this is even more of a reason why we need to make sure the 340B dollars are spent on healthcare, because we really need those resources now in healthcare. Looking down the road, how do you anticipate federal policy changes will affect the intersection of Medicaid and 340B? And what steps should stakeholders take now to prepare for these?
Appreciate that, Thomas. And I think it's an interesting question. And states have long talked about pressures in the Medicaid program. That conversation continues. Some states have said, because of that, we need to expand the 340B program and have no restrictions and no transparency. And I would argue that would be something that would actually hurt a Medicaid program. And what I mean by that is if you grow the 340B program and you have a recipient that can either be a 340B patient or a Medicaid patient, the hospital can choose. If it's more profitable for them to be a 340B patient, they will. And that's one less claim that goes through the Medicaid program, which will result in reduced rebates, drug rebates that go to the state Medicaid program. So I don't think unexpanded with no transparency 340B in the states is a solution for the Medicaid issue. I think you really have to look to say, how will this put a pressure on the Medicaid program by losing revenues and rebates? And that'll put pressure on legislators to come up with general revenue to fund the gaps. One thing I will say about the federal legislation is instead of using a program that was designed to be a safety net to address rural healthcare issues, underfunded issues in urban healthcare centers, there was a program with $50 billion to go to rural hospitals in that federal legislation. That kind of direct funding is a way to address issues. We've seen it in states where there have been financial pressures with federally qualified health centers. So some looked at, if we can grow the 340B program beyond what it was meant to be, that'll solve it. It won't, because it puts all these other financial pressures. So what they did in a state like Delaware is they gave funding directly to the FQHCs, saying, we know there's pressures and this is a direct way to solve it. So I think any conversation should be to look at, what's the funding, what are the pressures, and how can you solve it in a direct way instead of something indirect like 340B. Just going back to the private health insurance, there are studies that over the last 7 years, 8% of the increase in small business insurance premiums have been because of the growth in the 340B program. And so about 20% of that comes out of the employee's paycheck. About 80% of that comes from the small business. That growth is hurting small businesses that have to make the decision. I have 6 employees. It's very expensive to cover health. It's going up even more. 340B growth is a part of that. Do I just drop coverage or do I reduce my workforce? I mean, these are the unintended consequences that any discussion at the federal level or in the states with Medicaid, you really have to look at. I mean, this 340B is kind of a shiny object. Oh, we'll do that and we'll take care of it. You really need to understand the consequences of programs and moves like that.
Okay, Howard, I'm going to give you the last question. We've talked about some of the misuses of the program already, but there also are success stories within the program, especially in the early implementation phase of the program. Can you provide some examples of providers that are using this program in the right way, and what would make a good hospital that's involved in this program? What would make them good in terms of how they apply the use of the dollars in this program?
So when you look at the 340B program, it really was designed to help those safety net institutions that are providing a high number of Medicaid patients or underserved patients as well, or uninsured patients in this space. And so if you look at a hospital like the Detroit Medical Center, where they are seeing a high number of individuals that that are uninsured or have a high Medicaid population, 340B dollars are great in that facility because they are providing this care directly to the community. Let me back up right quick. 340B is only for outpatient drugs, and there's a certain formulary of what those drugs are, those dollars are to be spent on. And so when you start, and cancer is one of those areas where a lot of those drugs are put on these formularies that you get access to. Hospitals like Detroit Medical Center in Georgia and Atlanta, Grady Memorial Hospital does a lot of work in the community using these dollars to expand care, not to contract care and put it into things that are not healthcare related. These kinds of examples show how the dollars could be used and used effectively for the community to ensure that not only you get access to the drugs, but if you don't need the cancer drug, what services are being provided back to the community that this entity is using, and you can easily track those. If you've been working with a hospital system that used to do a lot of stuff and they don't do a lot of stuff now, I would look at them with a little side eye.
Dr. Thomas, if I just may, because I think Representative Mosby is being far too modest. He's an executive at the one of the top 10 largest hospital deliveries of services to the indigent in this whole entire country. I will tell you, if something were to happen to Grady Hospital, there would be a tsunami in Atlanta where it would shut down the hospital system as it was. And they're doing what you're supposed to do uh, with these kinds of bills. Many hospitals, I don't know if any associated with this program, but many are making money off of the backs of cancer patients, the poor, and the taxpayers, and that's just not right.
Okay. Well, please give a round of applause to this panel that we've had this morning. And any questions from the audience?
Let's go. Thought I could get out of here.
Yes, my question is the 340B. That plan is that for just Medicaid or for Medicare?
So those in Medicaid, Medicare. Okay.
I only have Medicare.
Right. And so if you are in Medicare, you could be a 340B patient. Okay. The problem is that because there are no transparency requirements, we don't know, and you don't know, if you are receiving the benefit of the discount of the program.
How can I find out?
So Thomas is right, and here's a caveat with the 340B program. When the drug's purchased at a steep discount, say 80% discount, you as a patient, whatever your coverage is, you still pay. If you have private insurance, you pay your copay. If you're Medicare, you pay your Medicare copays. That doesn't change. It's not reduced for the discount. So you wouldn't know if you're a 340B patient if you're uninsured in Medicaid, private insurance, or Medicare. And even if you were, you're not receiving that discounted price. You're still paying the full amount. So that's the nuance here, and that's why I'm sure most people, regardless of coverage type, have been a 340B patient at one point or another. But the way the program's designed, you don't get the savings from that drug. It goes to the institution, supposed to go to indigent care, but a lot of times, like we've talked about, goes to profit centers to build towers, operational expenses, salaries, beyond. So.
You asked a very key question.
Absolutely.
That we ought not be able to have to wonder how to get that information. And that's why so many of us here are advocating for transparency. We're advocating for making sure that that question can be answered so easily.
I just want to add one thing to this discussion, is as we advocate for policy to take care of ourselves, to make things accessible, we can't just stop at the what we want. We have to do a deeper thought, and that's across the board. We have to think about the end game. We have to add some discipline to our thinking. One of the disciplines I've learned in manufacturing is failure effect analysis mode. We need to look at what we want, how do we benefit, but we also need to process what are the potential shortcomings and what can hurt us, so that we could think about putting in provisions for transparency and accountability. Because when you open the door, that sheep can turn into a wolf if we don't put in the protections necessary at the legislative process. And we need to get ahead of it in the beginning, in the birth, as we move forward in policy creation to benefit us, that we make sure that we start those conversations in the beginning, not the end. Look here in Detroit, all of the eyesores of devastated buildings from the manufacturing era, right? We gave up land, we gave tax abatements, we gave this. We brought into their business plan, right? But at the end of the day, after that business plan died, they leave, they hold the property, they write it off in taxes, right? They receive a benefit, and at the end of the day, who pays to clean it up? It's the taxpayers, right? It's the people. And who gave up the land and created the tax abatement? It all came from our struggles. All of this comes from the struggles of the working class and those that provide labor. So we need to stand up and not just look at what we want, but make sure that we engineer provisions to protect us at the end of the life cycle.
Yes, I would like to know when you get a prescription from a doctor, and do you know exactly how much your pills cost? The prescription that he give you, how much do it cost? Because I had got a prescription from a doctor one day. Went to pick my pills up, and my pills was $500. I looked at the man and I said, do I look like I can pay $500 for these pills? And so I just want to know, when a doctor writes a prescription, do you usually know how much the prescription costs when you give it to them? And why can't they give you pills that really don't cost that much?
So
You don't want generic.
yeah, I'll try to do the short answer to that, because I mean, we could talk about that for hours. But long story short, drug manufacturer and the pharmacy where the patient gets the medicine, there's a lot in between that. Insurance plans, PBMs, and so there'll be a price at the manufacturer level. Then there's a lot of stuff that goes on in the middle, and then you get to what the actual price of the drug is. It's going to change based on insurance plan. I know in my house we have a prescription we get every month, and we have the same insurance, and it costs something different every month. Sometimes we use GoodRx, and it's cheaper than the insurance amount. Sometimes the insurance amount's cheaper. So to answer your question, there's a black box between where the drug's made and where it gets to the patient, and it's a very complex system. So should you be able to know exactly what it's cost and have some transparency and how that dollar moves through the system? Absolutely. That's not how it's designed right now. And we'll probably leave it at that, because we could talk about that for a couple hours. And I will say this, any legislator in the country that wants to help patients out, there are things you can do, like all the rebates that are paid in the system require a portion of that to be paid to the patient at the pharmacy counter to reduce the cost of their drugs. It's a convoluted system, but that's one way that we can try to get some of what's in the middle of the system to the actual patient. So
You know, someone I know of, 38 years old, has that neurofibrosis mitosis part 2, and he's confined to a wheelchair, 38 years old, and just recently his Medicaid part B was cut because he made $27,000 last year, and they said he made too much. So now he's reapplied. So his medication is going to cost over $100,000 a year. Is there some way, if you don't have Medicaid Part B, that you can get your medication reduced? Is there some other kind of program? Would this program help him, possibly?
So the 340B program won't help directly reduce the cost of his medicines, but if somebody's on Medicaid and then loses coverage and their costs increase, or if they become uninsured, or there are programs through drug manufacturers for coupons and patient assistance to help offset that cost. In certain instances, it can take it down to $0 copay, but is that a perfect model? Absolutely not. But is it the drug manufacturer's attempt to see situations like that and try to help get people reduced prices and better access to medication? There are programs like that. So whatever company makes the drugs, I would say check with that company and see if there are assistance programs available.
Okay, and that was part of my question, the patient assistance program. Every drug manufacturer, when I call for patients as a patient advocate, they're supposed to have a patient assistance program where the patients can actually call the drug who made the drug and actually request assistance to pay for that drug or get the drug free based on their income. So, but they don't really tell the consumer that. So that's something that should be included when the doctor speaks. But to ask the lady's question, she asked you, does the physician or the doctor know the cost of the medication? Because drug reps come in their offices all the time to make deals so they can get refunds.
Yeah, I would say they probably don't know what the cost is, because you can have the same doctor prescribe the same medicine to two different people. One person's on Medicaid, three different people. One person's on Medicaid, one person's on an HMO private insurance, one person's on private insurance PPO. And so that cost for that drug, when they get to the pharmacy counter, is going to be different for all three. So doctors wouldn't know that generally.
All right. Thanks, everyone. Appreciate it. Thank you.
All right, let's give our panel another hand. Thank you so much, Thomas. All right, we're going to move right to our next session. All right, we have a mental wellness and behavioral health that is going to be presented by Ashley Lee. She's a licensed, she's reached a master's of social work degree from Florida State University and then completed an internship at the Mayo Clinic. She's with us a lot. She works at the Department of Veteran Affairs, like I do. She previously served as a community engagement partnership coordinator and now veteran direct care coordinator. She will be addressing mental health, wellness, and behavioral health. Get Ashley a hand as she comes again. She's somewhere here she is. To talk about mental wellness and behavioral health, okay? I'm gonna put you on the clock. The clock is right here now, okay? You see it?
All right, good morning or good afternoon, everyone. My name is Ashley Lee. I'm a licensed clinical social worker. And as Stan said, I currently work with the Department of Veteran Affairs. And today we're going to talk about can be a sensitive subject, which is mental health and suicide prevention. So if you need to speak with me afterwards or talk, feel free to grab me. I'm more than welcome to have a conversation with anything about anybody that's struggling with anything. So we're going to talk about mental health and suicide prevention. We're also going to talk about access to lethal means. And then I'm also going to provide you with some wellness tips as well. All right. So I like to start off with telling people healing and operating in our purpose and our endeavors. That's my goal with this discussion. Some people are diagnosed with cancer, various types of cancer, dealing with diabetes, depression, different things. And so my goal with my presentation is to make sure that we're operating in our purpose and our endeavors and making sure that we are inspiring each other and giving each other hope. All right. I'm going to give some general mental health statistics. If you're not aware, 1 in 5 U.S. adults experience mental illness each year. 1 in 20 U.S. adults experience serious mental illness. And 1 in 4 people with mental illness have been arrested in their lifetime. 2 in 5 adults in jail or prison have a history of mental illness. We're also talking about the youth. 7 in 10 youth in the juvenile justice system have a mental health condition. All right, Michigan. So in February 2021, 39.9% of adults in Michigan reported symptoms of dealing with anxiety or depression. But approximately 27% of those individuals were not able to get services for mental health. 355,000 adults in this state have a mental illness. 1,540 folks in this state lost their life to suicide. So that just tells you, I'm not going to read everything, but it just underscores mental health is real. It is happening not only across the U.S., but the impact of it in Michigan and in this state, and people that are losing their lives to suicide and that are struggling, and how can we provide and get them services. 1 person dies by suicide every 10.6 minutes. So just think about the time that we've been in here, the time that it took you when you got up this morning to get ready, get dressed. That is how many people have lost their life to suicide today. So every 10 minutes. Every 25 seconds, 1 person is attempting suicide. So there's somebody who is struggling and battling with thinking about taking their life or attempting to take their life. 1 male dies by suicide every 13.4 minutes, and 1 female dies every 51.5 minutes. So again, just thinking about the time that we're spending in here, people are losing their life. Suicide is the 11th leading cause of death in our country, and homicide is the 16th. So that what that tells me is we're taking our lives more than we're harming each other, and that's a serious issue and concern. And I think it just underscores just that amount right there. 49,476 people lost their life to suicide in 2022. So that's a huge number of people who are suffering with a mental illness and they felt like they couldn't deal with their issue and they felt like their only recourse was to take their life. Next slide. So I want to talk about signs of mental health. Sometimes it's not open. Like, you think, oh, this person's going to be sad. They're going to be depressed. They're going to be dealing with anxiety. Sometimes we can be going about our day and we can appear perfect. We appear strong. We appear that we're excelling in our life. And those folks who are strong, like we tell people, check on your strong friends. They cannot handle everything. They cannot deal with every battle. They may look like they're doing well financially. They have a good job, the car they want to drive, they have a family, all those things. That means nothing if I don't feel well on the inside, if I feel empty, if I feel like something is missing, if I feel like I'm not adequate enough. All of those things means nothing. But obviously, these are some signs. If you know that someone's dealing with guilt, excessive worries, stress, look out for people that are having financial challenges, a new diagnosis. All of those things can lead to you feeling like I'm struggling. I might not want to be here, right? Because for someone who's particularly going on the journey of cancer, that is changing your life, right? The person who's taking care of you, your spouse, your significant other, your children, that is a change in their life. Your job, your financial stability. Am I able to continue to work? Do I have to take FMLA leave? All of those things are things that come up when you're going through a journey with healthcare. And then also battling with sex drive, changes in your relationship. If you're in married or you're in you have a significant other, it changes your relationship dynamic. You feel like you're more so this person's caregiver than their spouse or their significant other. So looking out for those changes. Obviously, alcohol and drug use, excessive eating, your eating habits, whether you're overeating or not eating enough, and then concentrating. That's another thing. If you feel like I can't concentrate and get through the day, whether you're driving, you're dazing off, or even throughout the workday, you can't focus on things, looking out for those things. These are some risk factors for mental illness. So chronic medical conditions, brain damage, history of trauma. If you've ever had a concussion or even played different sports or anything and had brain injuries or trauma, concussions, history of child abuse, somebody who's dealt with being talked to in an inappropriate manner as a child, emotionally, sexual abuse, physical abuse, domestic violence. Whether you're the person who experienced or you were watching that in your home as a child, all of those things can lead to someone having being at risk for mental illness. Your environments, inherited traits, those are all comes from how we grew up in our families, and then your brain chemistry makeup. All of our brains think differently. Somebody can give a presentation and we can all come away with something different from the presentation or how we interpreted what the person said or what they meant. So all of that plays a part in our mental health. Concerns with seeking treatment. Big thing that we've always talked about here is limited access to care. There are not enough mental health professionals. You may not have the health insurance. Like they were stating, whether you have PPO, HMO, lack of insurance, Medicaid, not being able to find someone in network, not being able to find someone that you identify with that may be a female or maybe a person of color. All of those challenges play a part in it. Lack of social support, transportation to get to the appointments. All of these things can lead to your concerns with seeking treatment. I will also say fear of judgment in your community, your surroundings. I hate to say it, but if you're used to calling somebody crazy or look at that crackhead or whatever, all these types of things that we say and we think they're in a joking manner, if somebody's really struggling, I'm not going to come to you because I felt like I remember them calling that person that. I remember them saying that person is mentally ill. They're disturbed. Don't play over there with that person. Don't mess with that person. Why would I go seek help? Why would I tell you I'm struggling? Because all of those things are running in my head where it concerns me getting treatment. The other thing that I will say is loss of employment, which is a big thing. Because if you feel like, you know, I'm struggling, but I need this job. If I go seek counseling through EPA or any of these other services, what's going to happen to me? You know, what's going to happen to me if I take FMLA leave? If I'm not here, is my job at risk? You work in an at-will state where they have a right to fire you and let you go, and I don't have an explanation for you. So all of those things lead to a concern with someone wanting to seek treatment. How we can reduce the stigma around mental health. Again, we want to stop calling people crazy, lunatics, psycho, mentally challenged, even, you know, terms related to substance or alcohol use, crackhead, deadbeat, all these kinds of things. We want to stop using that language. Also, in terms of people who have lost their life to suicide, we want to stop using the word committed, right? Because if I'm committed to something, that means I dedicated my time and my energy to do that, to have that end result. That's what I wanted. We want to say they lost their life to suicide because that was a battle, right? That was a battle that that person struggled with mentally for God knows how long before it got to that point, whether it was a suicide attempt or they lost their life to suicide. So we really want to take it in from a health perspective as well, that we don't want to make mental health different from your physical health. We want you to be well overall with your health. That includes your physical and your mental. We want to learn to validate our loved ones' experiences. When somebody comes to you with a challenge or problem, validate them. I don't need you necessarily to fix what I have going on. Validate me how I feel. You know what? You're going through this, and this. I can understand why you would feel that way. We don't need to brush each other off and say, girl, it'll get better. Pray, go to church, stand in the moment with the person and feel their experience. How can I help you out? How can I support you? What do you need from me in this moment? Maybe I just need you to listen. If I need a solution from you, maybe I need you to help me get a plan together. Can you take me to my doctor's appointment? Maybe I don't know anything about my insurance and what it covers. Can you call for me? Can you go to my appointment with me? These are the ways that we can help someone tangibly with their mental health and their wellness, because we're not all intelligent. We don't have all the answers. Everything is not our forte. So if I come to you with something, help me out. Don't assume that I know how to do it, or I know how to call, or I know about my insurance or anything. Walk me through the process if you know how to do that. The other thing is advocate for yourself with your providers. Ask questions. Period. Ask questions. Don't be afraid. No question is stupid or dumb. Ask questions. If you have a nurse, if you have somebody that you know in the field that can come in and sit with you, bring those folks in with you. There's a lot of stigma and shame. And I don't want this person to know my business. And I don't want this, and this, and that. Listen, this is your health. If nosy cousin has the answer, be quiet, ask the questions I need you to ask, help me out, and I'll discuss with you what I need to discuss with you afterwards. But don't be afraid to have somebody that can come in and advocate for you on your behalf, because you want the best result. Always seek a second opinion. If you don't trust what you're receiving, ask somebody else. If you get the same answer, okay, good, it confirms that. If you feel that the other provider has better healthcare service delivery or outcomes, go with that person, but always seek a second opinion. If you have a concern, question, issue, I think one of the women brought up the issue with medications. Different medications can treat the same diagnosis or disease that you have. If something can be, if you can get warfarin over Lovenox and you haven't been tried on warfarin for whatever reason, ask the question, can I try this lower medication? And if not, I need the higher medication. Why? What's going on with me medically that I need to have the Lovenox over the warfarin or the other middle price drug? So always ask and seek and get those second opinions out in your community. All right. So signs about suicide. Riskiness is the same thing. risky behaviors, if they're driving erratically, increasing substance use or alcohol use. Maybe somebody is used to having a drink 1 or 2 times a week. They're drinking every day. They're drinking a pack of beer and you're used to having 1 beer a day. Look out for those types of things. Driving recklessly, erratic, making statements about, I don't care about this, I don't care about that. Also feeling like you don't want to be here anymore. When someone starts telling you they're a burden, pay attention to that. I'm a burden. I don't need to be here. I just cause issues. I'm a troublemaker. Pay attention to those things and dive a little bit deeper with that person. Also with sleep, hopelessness, anxiety, we talked about those things. But the main thing that I tell people is use some of these statements up here. Let them know that you hear and understand them. Ask the question directly, are you having suicidal thoughts? Do you have a plan in place to harm yourself? You need to know that. We don't want to play around with that question. Are you not feeling well? Are you feeling bad? No. Are you having suicidal thoughts? Yes or no. If the person hesitates to answer the question, that's kind of an indicator as well. And then how you can encourage them to get them some treatment or access care. Walk them through the process. If you need to go to the hospital with them, can I sit in the ER with you? If you need to get something to be evaluated right then and there, walking them through the process. If you know someone's starting a new medication, how are you feeling? Is the medication making you feel better? Are you sleepy? Are you irritated? Follow up. Just because somebody gets a medication and they're going to therapy, it doesn't mean all is well. Sometimes that medication might not work for them. They need an adjustment. They need a higher dose, a different medication. So don't just think because somebody's getting treatment that everything is well. Continue to check in on that person to see how they're doing. Okay? And then we also already talked about that, how you can expedite assistance. If somebody has a plan in place to harm themselves, they have access. They have access to a firearm. They have access to knives, whatever it is. Take that seriously. We don't expect for you all to be mental health professionals and know how to get somebody assistance, but you can take somebody to the ER. You can call the crisis line on somebody's behalf. And that's a thing that a lot of people are not aware of. You know, I always tell people if someone were to fall out right here, you would call 911, right? You don't know if they're having a heart attack, stroke, whatever, you're going to call. If somebody's a nurse in here, you're going to try to help the person, right? Same thing for mental health. Call 988 if somebody is in crisis. Take them to the ER if somebody is in crisis. We're not expecting you all to be mental health professionals, but you can walk that person through the process. You can try to get them assistance in whatever way that you can. And we talked about this access to lethal means. Obviously, be safe. If someone's in immediate danger, get them assistance, take them to the ER. I'm not going to advocate or tell people to call the police necessarily on people. That would be a case-by-case basis if somebody's doing something. But if I can get you to the ER, I'm going to try to get you to the ER. If I can talk you down off the ledge and sit with you for the night, that's what I'm going to do until we can work things out in the morning. We talked about that. If you have thoughts and plans and access, putting time and space in between that person. Everybody needs to have the crisis line phone number in your phone. You can call on somebody's behalf, have it on your refrigerator. Time and space in between somebody being in a suicidal crisis and having those thoughts, and then actually putting something into plans and access and accessing a firearm or anything like that. Text, calls, pets, anything like that that can disturb. Or also if somebody, I'll give you an example with a firearm. If you store the ammunition separately from the firearm and you have like a lockbox or a gun lock or something like that, that is going to create time and space between that person being in crisis. And then if I have to run over here and go get the keys and then I have to go over here and find where the ammunition is, it gives me time to second guess something. Somebody can ring the door and like drop a package off. What am I doing? You could call that person. All of those things leaves time for interruption so that person can still be here with us. And then as we noted at the end, suicidal crises are brief. 90% of those who attempt suicide will survive. They will not die. So suicide is preventable. We can help people, but we all have to be cognizant of people not doing well in our community and how we can assist them in our own ways. Lastly, wellness tips. Touch grass, walk, literally get some vitamin D, do light yoga. If you're not in the best shape physically, you can do chair yoga, move your legs, exercise. These are all small little things that we can do to take care of ourselves. Meditating, journaling, art, all of those things. We need to be mentally well in order for us to deal with our physical challenges or our battles, whether that's going to work, dealing with particular people, our families, everything like that. If we're not mentally well, we're not in a space to handle all those things. We're not in a space to help other people out because our mind is our first focus, and then that helps us with getting our body and everything else in order that we need to so we can get through the day. All right, last slide. Be engaged, be supportive. Let's help our friends. Let's be listeners. Let's learn to validate each other and be engaged in our community. We cannot do this alone. There's not enough mental health professionals in the community. There's not enough people that know about people who are having challenges. But you know when your friend is having a challenge. You know when your mom is, your aunt, your sister, your siblings. We know when somebody's acting erratic, when they're not right, when things are going on with them. It's up to us to step in and challenge that and see how I can assist that person and ask a question and how are you feeling? How are you doing? And really be invested in that experience and knowing that and how we can assist those folks. And then here's some resources out in Michigan. There's also a handout for mental health resources for the Michigan area as well. And these are some things specifically to the Detroit area. And that is pretty much it. Thank you for allowing me to speak.
Thank you, Ashley. She'll be a part of the panel after we have the next discussion and for our next panel member. So have your questions ready. And St. Patrick, get ready and let me know if they have at the end here what we have. Our next presenter is going to be Amy Richardson. She's a health educator, tobacco treatment counselor at the Henry Ford Health System. She specializes in tobacco treatment and motivational interviewing. She's part of the team that's been instrumental in the Healthy Heart Project and Quit Smoking Virtual Support Group. Today, Ms. Richardson will be speaking to us about smoking cessation, providing support and resources to assist patients with quit smoking. Give her a hand as she comes, Ms. Richardson.
All right. Hi, everybody. Good afternoon. I am used to talking with people, not at people. So bear with me if I ask you some questions. Yeah, I have the great pleasure of helping people quit smoking with Henry Ford. I started helping people quit in 2013. So that's 12 years that I've been talking on the phone with people about quitting smoking. So I've heard it all. And today I'm just going to talk a little bit through the benefits of quitting. What is the disorder? It's a disorder. Talk about developing a quit plan, a few tips on how to cope, and then also there's medications that can help you quit. So I'm going to talk about those as well. Okay, so there's many benefits to quitting smoking. We know that smoking is the #1 cause of preventable death and disease. And so it's very important to quit smoking, but it's also important to get motivated to figure out why you want to quit. I know not everyone in here is a smoker, but this might help you have some conversations with your, loved ones about why they want to quit as well. And so, we could say, I want to quit for my health. But when I'm talking with people, I want to hear more about that. Like, what does your health mean to you? It could be tied to wanting to chase the grandkids around. It could be tied to, I just want to be able to get up and down the stairs to get my groceries in and out of the house. So really thinking about what your health means to you personally and breaking it down into those levels can help you kind of visualize what my life might look like if I were to quit. Oh, can we go back? Sorry. I just want to talk about like the money savings too. It's an incredible amount of money that can be saved. Like you could go on a cruise by the end of the year if you quit smoking. So that's a huge one. And, that's a rewarding experience too, the financial benefits, just to watch them stack up. People are paying $10, $11 a pack a day, a day. That's $300 a month. Also, kids, sometimes the kids are getting to that age where they start to say, "Mommy quit, why are you smoking?" Or even the grandkids start to bring it up. And so you want to be healthy for them. It can also improve your appearance. You don't have to deal with the smell anymore. And freedom. How about those Michigan winters and not having to step outside to smoke? That's a big motivator for some folks too. But again, the main thing is to think about why you want to smoke. And one of the first tasks that I always give people is to write them down. So these reasons to change float around in the brain for a long time and they float away. And if you have them down on paper, it makes it much more real. And I also encourage a pros and cons list. So when I ask people, why do you smoke? What are the benefits to smoking? You might say, I enjoy it. It helps with stress. It fills time with boredom. But if you break these down and put those side by side, the answer is obvious as far as the decision to quit. Okay, so why is quitting smoking so hard? It is so hard. It's more addictive than cocaine or heroin, if you can believe that. And the reason is because when you take a drag off a cigarette, it reaches the brain in 7 seconds. That means you get that rewarding dopamine feeling almost instantly. And so it becomes very addictive. When you quit, why is it so hard to quit? There's physical withdrawal symptoms. So those are things like feeling irritable, feeling down, anxious, not being able to concentrate. And then a lot of people will say, forget it, I'm going to go have a cigarette. This is too much. And then there's also the psychological aspect of it. That part goes on a little bit longer than the actual physical withdrawal. So unfortunately, grief can happen. Things can happen while you're trying to quit. And the first thing you think of to do is smoke a cigarette. And so we see a little bit of relapse with this condition. And we also have obviously the habit side of it. So one way to think about why is it so ingrained in my brain? One of the things I like to do is break it down for people. If you smoke 20 cigarettes a day and take 10 puffs off of each cigarette, that's 200 times a day you're dragging off a cigarette. And what's 200 times 30? It's a lot. If you multiply that, it ends up being into the millions if you calculate how many times a smoker has taken a drag off a cigarette. And so, the first thing to think of is to do that. Another thing I like to mention too is you can, why does it get so ingrained in the brain? Think about brushing your teeth. You don't have to think about it. We don't have to think about going into the bathroom. We don't have to think about we're going to grab the toothbrush, we're going to put it under the water, you know how to brush your teeth. It becomes like similar with smoking, where it's just a natural automatic process picking up a cigarette. And so one of the things I do with folks is work on some strategies to break that automatic process. But this is why it's so difficult to quit, and we address all of those with you in our telephone program. Okay, so you decide you want to quit, you wrote down your reasons, you understand the addiction cycle, you know what's going on here. So then what? Next, you're going to start to make a plan to quit. So you can see, keep a journal. I'm not talking about a journal where you might write down how you're feeling, what happened that day, those sorts of things. What I'm talking about is writing down each time you smoke, which is pretty simple. But what it does is it places a pause of awareness in between you and lighting up. So that's going to break that automatic process. Keeping a journal also helps to identify triggers. So when you write down the time that you smoke, you're going to write down what the situation was. First thing in the morning, after meals, driving in the car, talking on the phone. You're going to identify when and why you smoke throughout the day. Okay, so now you've determined when and why you smoke. And for each of those, what I do is have you come up with a plan. So If every morning you wake up and have a cigarette first thing with that cup of coffee, I don't know about you, but I'm not thinking very clearly when I first wake up. So you're going to want to have a plan ahead of time for how you're going to change that routine. So it might be even sleeping in a little bit longer. Maybe you go out for coffee instead of having it in, drinking in a different room. But whatever it is, you're going to come up with a plan to change that situation up. So plan ahead. And then once you got yourself prepared, you know how you're going to handle all of these different situations. What you're going to do is come up with a quit date. It's a good idea to have a quit date. A lot of folks I talk to are just like, I'm just going to do it. I'm ready. You've convinced me. But setting a quit date and planning and preparing ahead of time is going to give you a good opportunity to give that attempt your best effort. And then you're going to quit on that date, and then you're going to reward yourself. So smoking, you get that 7-second automatic feedback that this is a good thing to be doing. We want to also make sure that it's a rewarding experience. You're not just giving up cigarettes and you're deprived and just living a life with no cigarettes. No, you want to reward yourself. So find some ways to care for yourself, and they can be really simple things. Plus, you're saving money, and you're going to be going on a cruise by the end of the year. So that's something to look forward to. Okay, so one of the biggest things is I don't know what to do when this craving comes on. If you're not a smoker, you've never smoked, you might not have any idea what that looks like. But essentially, what's happening is your brain's getting hijacked by a need for a cigarette. And it's all you can think about. It's all consuming. And it feels like if I don't get this cigarette, there's just like, it's the only way out. However, the brain is very sophisticated. After 5 minutes of having that drug-seeking thought that you can't get off of, the brain goes ahead and releases some hormones that relieve that for you. But if you're so worked up and trapped with this thought, it sometimes is difficult to feel that sensation of the craving going away. So a few things that you can do for that 5-minute period. The craving lasts 5 minutes, whether you smoke or not. Do some deep breathing. 2 minutes of deep breathing is just as relaxing as taking a drag off the cigarette. And I actually practice this on the phone with people so they can actually feel like, oh, wow, taking a 2-minute timeout did actually help me calm down, focus better, etc. Drink some water. Getting up and going to get a glass of water, that just takes a few minutes. Do something else. So distract yourself. Chew gum, take a walk, call a friend. All of these are just suggestions. You are the expert on you. You know what you enjoy doing. You know what you like. You know what would feel good to you. So while I kind of will rattle off my suggestions, it's really more about us talking together about what do you like? What do you think might work here? And then delay, again, it will pass. It will pass. Okay, so what I do is I talk with folks on the phone. That means you don't have to travel anywhere. There's no cost. This is a community benefit program. And it's convenient because you don't have to come in. It's private. We provide long-term support. People always ask me, how many of these calls do I get? As many as you need to help you feel confident that you can stay smoke-free. And like I mentioned, those psychological symptoms can go on for about a year. And so if you need support, we're certainly going to continue the calls. We also can do medication prescriptions. So I don't think I included a slide on this, but there are now 6 different medications or nicotine replacement therapies that can help you quit. The nicotine patch, gum, and lozenges. For somebody who smokes a pack a day, they might put the nicotine patch on and say, it works pretty well, but, I took it off and had a cigarette. What I would do for those folks is prescribe some lozenges or gum to help with breakthrough cravings. So not a lot of people know you can use 2 so that you can be most successful. Those first few days, the physical withdrawal can be really, really challenging. So we want to make sure you're set up with what you need to have the most success. And of course, there's Chantix and Wellbutrin, and there's also a nasal spray, but we make sure that you're aware how they work, and so that you're most successful. If you've ever tried a patch in the past and it didn't work, it was 10 years ago, you can try it again. So you things change. You might be in a different mindset. It might work a little bit better for you the second time around. And we do offer some materials and things like that, but that's pretty much our program. And I'd like to answer any questions that you have for me. Oh, okay. All right. Thank you.
She'll be right back with our panel. I'm going to take a small break and do a commercial break for right now. We had some questions from St. Patrick about getting the lung cancer screening, so I want Cindy to come back and tell them again.
Hi, everybody. I just want to make sure that we keep this as accessible as possible. I know that some of you are not in this particular room with us, but on our eligibility slide that we have here at the very top is the phone number, which is 313-916-1275. Our team is in the office Monday through Friday from 8 a.m. to 4:30 p.m. If you call and you need to leave a voice message, don't worry, we will get back to you, and we'll do that eligibility screening over the phone, and also then getting you scheduled. So please don't let that be a barrier, to you getting your lung screening done. We'll be there Monday through Friday. Somebody's going to answer you. We do try to get all of our voicemails answered within a 24-hour period of time. So give us a really good phone number to get back to you, if that's okay. Thank you very much.
All right. Thank you, Henry Ford Health again. All right. We'll get into our last speaker, and then we'll do our panel for questions. And this is Mr. Anthony Beard. Mr. Beard is a registered dietitian and nutritionist at Heritage and Health Foundation, where he assists people on ways to develop proper relationship with their food and ends debate of what is good or bad. He feels that all food can fit into a healthy diet, that we can incorporate culture into the recipe with sound nutrition practices, active living, and wellness activities. Today, Mr. Beard will discuss nutrition as a factor supporting lung cancer and treatment. Mr. Beard. I give him a hand. Come on, wake him up too. All right.
Well, good afternoon now. It's good to be in the great city of Detroit, Michigan. I'm right next door in Ohio and from Cleveland, Ohio, and so I always love to come make my treks across I-80, 90, and then get on 75 and head to Detroit. So thank you for having me today. I'm going to sort of zip through the slides really fast because for the sake of time, be respectful of time. But I want to start out just as an introduction I put this first slide in to say dreams of my father, because back in 2020, my father actually was diagnosed with lung cancer. And so immediately I mobilized in my own mind that, okay, we got this. I'm going to use my professional and personal experience to try to get my father together and get him through this process. And I just want to let everybody else know that nutrition plays a very significant part in helping people manage treatments and any side effects, but also before, if you're going through the screening process or just in general, we all understand how important the nutrition component is. And with that, just to let you know, the RDs play a critical role as members of the interdisciplinary healthcare team. And one of the main things that we do is just by individualizing a plan. So there's no overarching nutrition plan. There's individual plans that are tailored for each individual because we're all different. So on the next slide, I just want to shoot through this really fast, but just to let you know that when it comes to cancer care and lung cancer in particular, there's the not so much it's dealing with the treatments, and the treatments could be immune therapy, it could be chemotherapy, radiation. All these can cause a host of nutrition related problems like messing with any part of your digestive system. You know, it could be swelling, it could be causing nausea, vomiting, all types of different problems that causes you not to eat. And that's one of the biggest problems is that when people present, they begin to deteriorate in some cases from where their normal baseline is. They begin to go downhill. And so that's one of the things that having that access to that nutrition care actually helps you walk you through this process because it can be pretty daunting process. And one thing I put down there before I go to the next slide is about triggering, where sometimes the treatments can trigger something else to start, where someone may not have even been diabetic or had high blood sugars, but as a result of maybe even their medication or something in the treatment process may trigger, and it can even sometimes be stress, can trigger a person to cause something else to start. And then it's now you have to address and treat that. So these are things that you got to look out for in treatments. And basically, what it does, it basically causes a whole bunch of nutrition related problems. For instance, chewing and swallowing issues where someone's gums may be sore or throat issues. One of the biggest things is taste issues where the taste of when you bite into a piece of chicken, a grilled chicken breast, you have an expectation of how that chicken breast is supposed to taste. Especially if you come to Detroit, because I know y'all good at throwing down when it comes to food. We know this. But when you bite into that and then it doesn't taste like a chicken breast, it tastes different, or you may have a metallic taste of something in your mouth, then now there's a problem. You begin to not eat, and then from there you start to go down and go down and go down. And so that's one of the things you have to look out for. And that's one of the things that I just mentioned is one of those what we call a food aversion, where you eat something and you could be put off by the smell. You can be put off by this new taste. And you also can be put off just by sometimes even looking at food. I've heard people saying, you know, if I even look at that, it just makes me feel sick. So I just didn't feel like eating. And, you know, it can also cause nutrition problems with the bowels. And that's one of the tough ones where you know, it's already bad enough you're going through certain treatments. And then if you're running back and forth to the bathroom, you know, it can just cause people to even going back to the mental health part, it can actually make people feel depressed in this state. So that's one of the things that we try to slow down. And some of the ways to solve some of these problems is by eating smaller meals and more frequently. And that helps with just about anybody in whatever uh, state you're in with eating, is to try to break things down into smaller, more frequent meals rather than eating three big meals, even though that's what we are used to doing. And also modifying the texture of different meals instead of having stuff in its whole state. Sometimes you have to break it down or help the body out a little bit. And so, as far as the nutrition needs are concerned, I purposefully left that up there for it to be, you know, the 25 to 30 calories per kilogram of body weight. You know, that's all Swahili in a certain sense. Basically, you have to eat basically what's on the general recommendation of eating. It turns out to be, you know, between 2,000 and 2,400 calories in a day. And that doesn't really mean much when you're not in a clinical setting. You're just out in these streets. You're just trying to eat to feed yourself and trust your hunger and fullness cues to tell you that, okay, I'm full, okay, I'm hungry. And the big focus is to focus on plant forward eating. And this is not to say that I'm promoting vegetarianism or veganism, not at all. You can eat plant forward and also at the same time eat meat, because basically we have the digestive enzymes and everything to be what we are, omnivores, eat meat and plant foods. But what we need to do is focus more on the plant part of the deal, because in those plant foods, there's certain chemicals that's in the plant foods. So, for instance, this is the end of August, and I'm pretty sure a lot of people may even have gardens. Here, see a lot of heads shaking. Yeah, we got some gardeners. So you have gardens, you're about to get this big yield, and even people who you know may be getting these big yields of different vegetables coming out. Well, don't turn them down, because inside of each one of those, if you look at all the different colors of all the vegetables, fruits, and so forth, each one of them has a chemical. So in that red pepper, there's a food chemical that helps you in your cancer and any other type of ailment that you have. There's food chemicals, green, yellow, blue, the purples. All of those food chemicals kind of come together and help you with dealing with whatever issue you may have coming on, but specifically in building up reserves and also helping you mitigate any type of side effects you may have from some of the treatments. And finally, on this slide, I just want to talk about dietary fiber. Dietary fiber is really important, and what makes it really important is that only about 17%, is the last thing I read, of Americans actually meet their dietary fiber recommendation, which is for women 25 grams of dietary fiber, and men, unfortunately, 38 grams of dietary fiber. Very few people, I do this every day, very few people reach either one of those numbers. And it's difficult because we just recently started focusing on whole grains, which is so important. Some people have a carb scare and they avoid grains because of the whole carb keto dieting type of deal. But we just haven't really until recently start focusing on eating whole grains. And I would suggest everyone, no matter what state you're in, whether you're lung cancer diagnosis and the screening process or after, is to try to find 3 whole grains and incorporate those into your diet. And because there's so many of them, everybody can find at least 3. And you got an easy one to start with, which is like oatmeal. That's a good one to start with. And then you can branch from there. Instead of eating rice, you can have something like couscous or sorghum, some type of grain, barley, something like that to bring in that gives you protein, fiber, and also all the food chemicals that you get and benefit from. Next slide. So I want to sort of close and talk about best practices of living the dream. And so if you're in this lung cancer situation, you want to it's mainly about trying to lessen the impact of the things that can happen through treatments and how you can just watch yourself degrade slowly and surely through a process of screening and journaling. And with screening, sometimes when you go to the doctor, you expect the doctor to catch things along the way before it gets really bad. But I would encourage anyone to, even yourself, or even if it's a loved one that you know, to do a self screening. And they have some self screen tools out there that you can Google. One of them is called the Scored Patient Generated Subjective Global Assessment, where it's just answer some questions. what is your weight? What was your weight 30 days ago? What is your weight today? How many meals have you missed? What is your appetite? Things like that, so that you can catch yourself before it gets too bad, or catch someone that you love before things get too bad. Do a self-assessment. And another thing that I like to challenge you with, everybody, no matter what, is to do a food journal. And just briefly, a food journal is basically you write down on a piece of paper, and they have tools out there, MyFitnessPal, or just you can get a piece of paper and do it. You're writing down what your normal eating pattern is: breakfast, snacks, lunch, dinner, and you keep that somewhere so that when you run into some type of health challenge, you already have what your baseline is already. And then you'll be able to compare as you begin to feel bad, not be the best representation of yourself, and you have something to compare, so you have something to reach up towards. And if you seek assistance and accept assistance for meal planning and preparation. Some people have a lot of, it may be pride, it may be something else where someone will say, hey, let me know if you need anything. Okay, yeah, sure. And never ask and never follow up. And sometimes, especially when people are going through something, they need to have that support and backup. So that could mean preparing a meal, a dish for someone, uh, making sure that they have foods that they can easily digest, because sometimes, once again, it's very difficult to deal with some of the side effects of some of the treatments when it comes to cancer treatment. And also, one thing that I like to say in closing is that don't forget about certain self-care practices, one of which is getting your proper rest, focusing on nature. I like the way you said, the speaker about mental health talked about touching some grass, being in nature. There's something that says nature is medicine. So just being able to get outside in nature, get some fresh air, still be able to move no matter what your circumstance or situation, be able to move, uh, because moving is important. And also, spirituality is really important, and connectiveness, because we all need to sort of be connected to ourselves and to the space around us, the universe of where we live, our spiritual practices. We need to be connected to that, because how you feel translates into what you eat and how you feel about yourself. And just so I actually have some patients who I see here in Michigan virtually through my one of my jobs, which is working with Swap Health. And I have driven here, several times a year if I have to see somebody in person. But if you have any questions or anything that you'd like to ask me, or anything, or if you want to see if you Swap Health is really good at making sure people are qualified to be able to be seen and get the health care they deserve. And that's one good thing about working with them, is and in some cases, even if people can't afford it, they actually do it for free. So if you or anybody needs someone to talk to in a nutrition sense, we're always there to help. And I would like to lead us into our question and answer session. Thank you.
All right, then. Thank you there, Mr. Beard. Can you stay up with us? I'm going to ask Ashley to come back up, Amy, and I'm going to ask Dr. Flano if he could come up as well and help us a little bit with the Q&A. St. Patrick, get ready to answer some questions with our audience. So Amy, Ashley, and Dr. Flano is somewhere. Where is he? Make sure St. Patrick is on. Ashley, we'll kind of start with you. You talked about mental health as emotional, psychological, and social well-being affecting how you think, feel, and act in a person. What about how that person is affecting somebody at church or at work? Does it have any bearing on what we're doing? I ain't laughing now. I'm being serious. Is it on?
Okay. Yes. So I like to operate off of a strength-based perspective, and basically what that means is if we have an issue or concern, we're going to talk about it, but we also need to talk about what the solution is because we don't want to keep swimming in our problems and this is happening and that's going on, and then we're spreading it to other people and we're impacting our environments. Like they say, you don't want to be like the Debbie Downer person. So we need to figure out when we're having an issue or concern or a problem, do I want this person to help me fix or address this issue, or do I just want them to listen to me? Because those things, you're going to get two different outcomes, right? So a lot of times we need to figure out, do I want this solution or problem addressed, or do I just want somebody to listen? And if you're just listening, we also need to be cognizant of how we spread that into other people's lives, right? So you have to give people time and space to vent, but then also too, if this is overwhelming you, just saying to yourself, you know what? We set aside this time to talk, and you know what? I have to get off the phone. I have to go cook dinner or do something for myself. There is a way where you can be supportive to people, but you don't have to let it also impact your life, right? Especially if we're not getting anywhere. We keep talking about the same issues and we don't want a solution, because we do know people that don't want a solution and we just want to talk. So that's what I would say to that person. Be present and supportive, but not at the risk of your own mental health, and put those boundaries in place.
Okay, this is for you and Dr. Fano then. Would you encourage our people, our community, if they got insurance, to go sit in the chair or lay on the couch and see someone about their problems?
Absolutely. I think if people realize that by reflecting on themselves that they need an outreach, they need to look into it, then I would encourage them any way they can to get what they think is going to be helpful for them. If that is going to be seen professionally, that's fine. If that's going to be stepping out, and like you said, finding some other release, some other hobby, some other activity that gets you to defocus and let you reset, I absolutely encourage that.
Excellent. Amy, you were talking about in your presentation something that you didn't touch on, maybe you can touch on with it for us right now, is secondhand smoke and those trying to stop smoking and maybe using that as an inducement to help them to stop smoking. We didn't hear a little bit about secondhand smoke in our community.
Great question. So secondhand smoke is dangerous. So that's inhaling the smoke that goes in the air that burns off the tip and is blown out of the mouth. A lesser known is third hand smoke. And that is one that doesn't get talked about a lot. That's where the scent and the residue is left on clothing. And that is actually dangerous to the children that you're around if you're holding a baby with those clothing on. So a lot of grandparents will say, I don't smoke around them, but perhaps you're still wearing the clothing that you had smoked in, and going to hold a new grandbaby, they're going to be inhaling all that stuff. So it not only protects you and your own health, but also your loved ones by preventing them from exposure to that secondhand and third hand smoke.
Earlier, Dr. Fano had a session on hookahs and cigars and Black and Miles. Does your presentation or your work talk about hookah bars as trying to stop them from smoking as well?
Yes, I actually get very few referrals on hookah, but we do see some folks, quite a bit of the cigars. We see like people will get those BLKs, the El Capones, all those little cigars. And so we do, this is an individual approach. So we treat all tobacco products. So vape, chew, the pouches are very popular now. So any type of tobacco product we can talk with folks about, and we can provide a referral if there's any need for treating marijuana smoke. We get some people that want to join our program for that, but we refer them over to some of our other programming that's more suitable to that.
Dr. Fano, and this young lady, she didn't want to ask the question. She asked me to ask it for you, to you. What about weed, stopping smoking marijuana? What are we doing? Maybe you and Amy could kind of piggyback to answer that. How do you work to stop somebody from smoking weed? I couldn't even help you with that one. I'm sorry. We'll see. We got some experts up here.
Well, I can tell you the health impact is actually real. It's become so socially acceptable, it's legalized, but we don't really understand the impact that it's having. But like I was explaining yesterday, we now know there is a link between smoking marijuana and developing cancer, as well as other health problems. You got to figure it's the same burning, whatever chemicals that are being inhaled and causing the damage. And so it is important to help stop. And the other thing that's not, even though there is some regulations, if you're going to, some of the stores that are selling or legally selling it, a lot of people are self manufacturing, rolling, and distributing, and that's unregulated. So a lot of times with those unrecognized health deleterious effects can be really impactful. In terms of an approach to stopping, I know you mentioned something.
Yeah, so Henry Ford has like an intensive outpatient program for substance use that we'll refer to, as well as we have behavioral health therapists that we refer to. And they are using probably similar approaches that I'm using as far as, an individualized plan helping you develop coping with stress, dealing with boredom, whatever like triggers and managing those and getting you into. Some folks use the recovery community to quit marijuana, and so that's always there's meetings and things available that they can refer you to. But
Okay. Let's see. Anthony, we haven't asked you a question. You see on TV now a lot about these meal planners. What's your thought as a dietitian and nutritionist about these meal planners that we see on television? How does that work with us? Is that something good for our community?
Yes. Can you hear me? Okay. Yes, the new meal plans are actually not actually a bad idea. They're expensive. That's one thing I can say for sure is that they're very expensive. They don't necessarily fit into the budgets of most people. And I'm talking plans like Factor, Cook Unity, things like that. But you can actually do it yourself by using some of the frozen. They've gotten really good with frozen meals nowadays, except for the sodium in them. But you can do it yourself by doing basic meal prep, sitting down on one day and actually portioning your food out and putting it in the refrigerator or freezer to have it ready. And that would actually help people in a number of different situations where you have a meal already prepared and you don't have to go through the process of cooking, because a lot of my patients, they sort of fall off the wagon in certain, depending upon what they're dealing with, because they just don't feel like cooking and they tend to buy out because they just don't have the energy. And if they had these meals, and I have some people who use those meal plans that have watched their hemoglobin A1Cs and diabetes drop all the way down into the normal range.
Okay, great. All right, so we're about to leave today. I want each of you to give us a take home as we prepare to leave today. And I'm going to make sure you come and see Cindy over here about our screening for lung cancer. And also want to again thank Amgen for being our sponsor. I don't think we have anybody from St. Patrick that wants to say anything right now. So we had a take home today for our audience today over at St. Patrick, and our visitors are with us right now. What would that be, Amy, starting with you? And we'll come down the line.
the take home I'd like you to take is you can quit smoking. It is a challenging thing to do, but if you spend more of your time on a plan and writing down your reasons and taking action steps, the rest will follow. It doesn't matter how many years you've smoked, you can quit.
I think my take home would be, you've heard a lot of stuff the past couple of days, a lot of information. If there's three things you remember that really made an impact with you that you can relate with or inspire somebody else, I would say take those three things home and then give them out. Give what you learned, because we don't get past these disparities, these health inequities, until everybody has good health literacy. And the only way we can do it is if we go out and educate the others with what you've learned.
I would say my takeaway would be how you do one thing is how you do all things. So if you're not taking care of yourself in one area, it's probably spreading and bleeding into other areas of your life. So making sure that we're not only taking accountability for our health mentally and physically, and how does the decisions that we make daily contribute to where we are going to be, whether that's being at our optimum health or being at a low level with our health care. And also as a community, helping each other out. You know, if you see somebody struggling, if you see somebody that doesn't know something, they maybe don't know the right question to ask, they don't know how to talk to their doctor, be an advocate for that person. We don't have to do this alone. We can take control of this issue in our community and step in and share that advice and spread the information. If you, like Dr. Flano was saying, if you have information, spread it to someone that you know that was not here today or needs to hear it, and keep talking to that person until they are able to get it and receive that information, and don't be afraid to walk them through that process.
Yes, my one takeaway would be something I mentioned during when I was speaking is to try to eat the rainbow and remember that those food chemicals are very important and you need all the different colors of fruits and vegetables. And I personal challenge to everyone is to try to incorporate vegetables into your breakfast because that's one of the areas where a blind spot where it sort of hinders the rest of your day if you're not able to at least get vegetables in at breakfast. So that's my takeaway.
All right, thank you. Give our panel a hand again as we wrap up here today. Let me thank the St. Patrick Senior Center for logging in and watching us live over at the St. Patrick Senior Center. We'd like to thank Pastor Horace Sheffield for hosting us this weekend. We'd like to thank our sponsor, Amden, for hosting us as well. And on behalf of our staff and board of directors at HEAL, thank you for getting some of this knowledge and taking it back to the community. Before you leave today, I need for you to do the surveys. These are hard copy this time. So they're in your package on your table, and you can give them to a HEAL representative before you leave today, just before you leave. I hope this has been informational for you. Has it? If it has, clap your hand. Tell me we did something this weekend. All right. Howard, you want to wrap up? Okay, don't forget about screening. I forgot about that. Don't forget about the lung cancer screening. Yes, sir, Mr. Thomas. Yes, sir. Yes, you can take a question. Sure. I was trying to take one. I just didn't come back that far. I'm sorry. Come on up. We might need the union again. I'm not sure. So you better come on up and ask a question. Sure.
Everything that you said is something within the last 3 years that's been put on my plate. To work with, I serve this PhD program across the nation, employee assistance program. We got 38 facilities across the nation for us to serve. And so with the PhD program, we deal with a lot of mental health referrals. And so we've always taken it on from a reactive, come to me, what help do we need? Our EAP reps are professionally developed by Wayne State, a 3-year certification program. But what happened is because the companies are global now, all right, because they're global now, in other countries like Italy and other countries, mental health and well-being has raised to the height where they know that it is one of the most important factors to be focused on for the workplace to really function and for everybody to benefit from the relationship. And so wellness, we're talking about food, health, and everything. We're talking about what you're dealing with in your community, what impacts you. That all impacts the workplace, and it has a high impact on workplace violence indicators. And so we've really got involved in that because I own ELC compliance as well. So we got in front of it now in an awareness. And what really excites me beyond just the awareness is we recently got involved with psychological safety, where management is now teaching managers how to manage people professionally around their mental health walking the floor, doing wellness checks on people. When they see a person, trying to get that person to the EAP rep so that they can start to work out a plan. So I am so encouraged. And the fact that I have a space to educate. So we're educating mental health awareness now across the nation with our members and got our EAP reps trained to deliver that message. And we just rolled out a psychological safety in our National Health and Safety Conference because it's tied to the Occupational Health and Safety Act, if I didn't make that connection earlier. And now with us being a global country, even though in America it's mentioned, they are starting to take action. And it's just great to see this dialogue coming out of COVID. We learned it, and all of us in this room is dealing with mental health issues. I got 36,407 members, right? 14,000 dependents, 14,400 dependents. And then 37,000 dependents and 14,000 spouses, a family of 88,000 people. And out of that, 13,000 actually reached out to get help. And so we're breaking stigma. And I can tell you, young people come into new hire orientation. Young people aren't scared like we are. They're reaching out and they're asking for help and going to get this mental health. So it's all important that us leaders at home and in the family, when we realize we're dealing with something, that we take the leadership role and reach out as help so we can combat stigma amongst our group and also show the kids a reflection that we're learning from them because they're reaching out for help. So again, I just want to thank you all. Thank you.
All right, thank you so very much. We'd like to thank our presenters and speakers for the 2 days that we've been here. Again, on behalf of HEAL and the board of directors, we are really thankful. Don't forget about our surveys again to make sure that works for you. Don't forget about lung cancer screening in the next room. And lastly, between me and lunch is going to be Minister Lamb to do the invocation. Did I miss anybody? Everybody's okay. Ms. Kapoor, you okay? Benita, you okay? Great, okay, all right. Gabrielle Howard, you okay? Rochelle, Rachel, you okay? Okay. Shayla, we okay? All right, okay. I've done my job. I had one job to do to get us out of here before 2 o'clock. I think I did my job. Okay.
Let us bow our heads. Our Father, thank you for the food we're about to receive, the nourishment in our body. We also thank you for the wisdom and the nourishment to our mind. Lord, please protect us in the days to come with a hedge of protection around each and every one of us and our families. As we go forth, let us take the wisdom. Let us take the wisdom, and may it be life changing to not only those in the room, but those here at St. Pat, which those that we come in contact with. We also, Lord, thank you for this group. We thank you for Amgen, Lord, for having the wherewithal to bring this for us, to help us change our communities in a way that we need like no other. We thank you for the gifts of each and every speaker that was here today. We thank you for the fact that they came, that they were willing to give. Lord, we thank you for allowing them to gain knowledge. And Lord, most of all, we thank you for you just being you. In the name of the Father, the Son, amen.
All right. I think we have a little lunch back there in the back for you. We're going to get a little bit of music. And if you would talk to our panel and to some of our members, greet Amgen before you leave today. And hopefully we'll see you very soon at St. Patrick or over here at this center. Thank you so very much. Travel safe. Good job, guys.